The Epilepsy Foundation is pleased to share with you an educational webinar on epilepsy and other neurologic disorders. The mission of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. My name is Dr. Elaine Kiriakopoulos, and I'd like to extend a warm welcome to everyone who has joined us today. The Epilepsy Foundation is working to provide information and education that serves the spectrum of individuals and families impacted by epilepsy. I'd like to review with you the format for today's webinar. Throughout the presentation, all phone lines will be muted. However, we would like to encourage everyone to submit their questions at any time during the webinar. To do so, type your questions into the question window on the GoToWebinar panel and click Send. We'll read your questions aloud and address them during the question and answer portion of the webinar. Please try to keep your questions general in nature, as the webinar is intended for educational purposes. This webinar will be recorded and available for viewing and listening on epilepsy.com. To guide us through today's learning on epilepsy and other neurologic disorders, I am so pleased and honored to introduce to you Dr. Joseph Sirven. Dr. Sirven is a professor of neurology and chair emeritus of the Department of Neurology at the Mayo Clinic in Arizona, and he'll soon be transitioning to Jacksonville, Florida. He is currently chair of the AAN Education Conference Subcommittee, and he is on the board of directors for the American Brain Foundation and the editor-in-chief of Brain and Life en Espanol, as well as serving on the editorial board of Brain and Life. Previously, he served as the former chair of the Professional Advisory Board for the Epilepsy Foundation. Dr. Sirven has published extensively on epilepsy and its treatment, and he is the editor of 7 textbooks. Welcome, Dr. Sirven.
It's a pleasure.
There are no disclosures for today's presentation. Today's webinar is going to provide an overview of common neurologic disorders that are often seen to occur in people who are impacted by epilepsy. During our time together today, we'll focus our discussion on stroke, Alzheimer's disease, brain tumors, and migraine headaches. Let's begin by reviewing some well-known facts about seizures and epilepsy, remembering that every brain has the potential to seize, and that anyone, regardless of age, race, gender, socioeconomic status, or geography, can be impacted by epilepsy. We know that seizures occur when there is abnormal and excessive electrical activity in the brain that disrupts normal brain function, and that seizures are common. 1 in 10 people will experience a seizure during their lifetime. If a person is found to have a risk for recurrent or more seizures, then a diagnosis of epilepsy is made. 1 in 26 people will be diagnosed with epilepsy during their lifetime. When a diagnosis of epilepsy is made, it's important to understand that alone, the diagnosis of epilepsy does not indicate cause. It does not indicate a person's outlook or prognosis, and that there are many different types of epilepsies, and there is also a spectrum for how epilepsy might impact an individual. Let's also take a moment to review the concept of comorbid disease. When a person's health is impacted by more than one condition at the same time, the conditions are considered comorbid. Today, as mentioned earlier, we're going to take a closer look at the relationship between epilepsy and 4 other neurologic disorders. As we make our way through today's learning with Dr. Sirven, it's important for you to have some general information about the 4 comorbid disorders he will discuss. To get a sense of how common each condition is, we'll take a quick walk through this slide, and let's begin right in the middle with epilepsy. We know epilepsy is a neurologic disease that affects 3.4 million people in the United States. For stroke, it is estimated that each year, approximately 795,000 people will suffer a stroke in the United States. There are roughly 5.7 million people in the United States impacted by Alzheimer's disease, and approximately 39 million people in the US who suffer with migraine headaches. We also know that each year, approximately 27,000 people in the US will be diagnosed with a primary brain tumor, and that about 300,000 people will be diagnosed with a secondary or a metastatic brain tumor. What these numbers highlight is that a large number of people are impacted by neurologic conditions. And it's so very important that we work as a community of scientists, clinicians, advocates, patients, and families to improve the health outcomes and quality of life for people impacted by these diseases. Working to understand the relationship neurologic disorders have with one another is vital to progress. Now, the human brain is a complex and dynamic structure, and we know that the average human brain has roughly 100 billion neurons, and that each neuron may be connected to up to 10,000 other neurons, passing carefully balanced signals to each other via trillions of synaptic connections. We also know that the human brain is susceptible to injury from disease, which can influence both its structure and its function. And we know by its response, sometimes in the form of a seizure, the brain can be unforgiving to insults that result from other disease processes. Now let's take a moment to review some basics about the 4 neurologic disorders we'll be discussing today, beginning with stroke. A stroke is a sudden interruption in the blood supply to the brain. The majority of strokes are caused by a blockage of arteries leading to the brain. These are referred to as ischemic strokes, and they're the type of strokes that keep blood from reaching brain tissue. Other strokes can be caused by bleeding directly into brain tissue when a blood vessel bursts, and these are referred to as hemorrhagic strokes. The most common cause of hemorrhagic stroke is uncontrolled high blood pressure, something which is also quite common. Now, stroke is the 5th leading cause of death in the United States and a major cause of disability in adults. Although most of us think of the elderly when we think about stroke, we know that stroke can also affect infants and children, and that pediatric stroke can cause both significant disability and death. Recent advances in stroke treatment have reduced death from stroke, but the number of stroke survivors with significant complications and disability has increased. Alzheimer's disease is a type of dementia that causes problems with memory, thinking, and behavior. Symptoms usually develop slowly and get worse over time, becoming severe enough to interfere with daily tasks. In Alzheimer's disease, 2 abnormal structures called plaques and tangles are the prime suspects in damaging and killing brain cells. Now, autopsy studies have shown that most of us will develop some plaques and tangles in our brains as we age. However, people affected by Alzheimer's tend to develop far more and in a predictable pattern, beginning in the areas important for memory before spreading to other regions. As neurons are injured and die throughout the brain, connections between networks of neurons may break down and brain regions begin to shrink. By the final stages of Alzheimer's, this process, called brain atrophy, is widespread, causing significant loss of brain volume, and you can see that change in the comparison images on this slide. Alzheimer's is an irreversible and progressive disease. It is the 6th leading cause of death among all adults. The causes of Alzheimer's disease are not completely understood. However, a combination of genetic, environmental, and lifestyle factors are felt to play a role. And we know that more than 90% of people with Alzheimer's disease symptoms do not appear until after the age of 60, and that the incidence of Alzheimer's increases with aging. Moving on to brain tumors. A brain tumor is an abnormal growth of cells in the brain that can disrupt brain structure and function. Doctors refer to a tumor based on where the tumor cells originated and whether they are cancerous or not. There are well over 100 types of brain and central nervous system tumors, and brain tumor symptoms can vary according to tumor type and location. There are times a person may have no or few outward symptoms when their brain tumor is discovered. For others, seizures can be one symptom of a brain tumor, and for many people, seizures are an early symptom, which can help lead to diagnosis. If we take a moment to look at the two MRI images on this slide, what you can see is the abnormal dark circle of tissue surrounded by an irregular bright white rim, the brain tumor, and surrounding brain tissue changes related to the tumor are quite obvious in this case. Now, these images demonstrate how a tumor and the reactive changes in the brain tissue that surround the tumor can cause the brain's normal structure to be interrupted or displaced. And this type of pathologic change can lead to functional changes, including seizures. A primary brain tumor starts in the brain and can be either benign or malignant. There are also secondary brain tumors or brain metastases, which arise from cells related to cancer coming from elsewhere in the body. Brain tumors are the 10th leading cause of death for men and women and are the most common solid cancer in children under age 15. They are the second leading cause of childhood death due to cancer. Brain tumors are most often diagnosed by brain imaging, and MRI scans are typically used, and biopsy of the abnormal cells is done to help guide treatment. There are several different treatments available to treat tumors of the brain. Let's move on to migraine. Migraine is a recurring type of headache that can cause multiple symptoms, including debilitating pain. Migraine is a neurological disorder that involves brain pathways and brain chemicals, and we know that both genes and environmental factors can play an important role in migraine. The images here on the right are taken through different levels of the brain, and mapped in red using PET scanning are areas of the brain that were activated in this person during a migraine attack. Advanced imaging techniques like this are allowing us to learn more and more about how and why migraines occur and the areas of brain involved. Headaches are among the most common nervous system disorders and affect about 15% of people in the United States. Migraine headaches are associated with burden that may include pain, disability, financial hardship, and a reduced quality of life. Migraine is often lifelong and is generally characterized by recurrent attacks that include a one-sided, moderate to severe headache, often described as pulsating. And we know the intensity of these headaches can be aggravated by sound or light, and it's not uncommon for nausea to accompany a migraine. Migraine symptoms and duration can vary, lasting anywhere from hours to days. And we also know that children can experience migraines. And in children, migraines tend to be a little bit shorter in duration, and they have abdominal symptoms, which are sometimes more prominent. At this time, I'm going to hand things over to Dr. Sirven, who will be sharing with us the relationship of epilepsy to each of these neurologic disorders. Dr. Sirven?
Hey, thanks, Dr. Kiriakopoulos, and it's a pleasure to be here with you today. So let's kind of review these different conditions and how it works with epilepsy. And we'll start with literally the biggest and most common relationship, and that's epilepsy and stroke. Let's further subdivide this by looking at the issue of seizure, and then the word epilepsy afterwards in its relationship to stroke. So next slide. So we know seizures can occur very frequently after a stroke, particularly in adults. Stroke is the most common cause of seizures and epilepsy in population studies of adults over the age of 35. And it's divided into two groups, early onset versus late onset. Now, early onset seizures that are associated right after stroke, they often extend the length of the hospital, which means that the hospital bill goes up. They can result from what naturally happens with the stroke, which is that you have cells that are dying off. And as a result, you get these different pathologies, excessive excitability, ion channels that aren't working, the blood-brain barrier disruption, and that causes the seizure. Now, late onset seizures, that typically is after the first week of having the stroke. And in that first week, you may find that there are changes that occur after stroke, which is inflammation, there's scarring that occurs, hyperexcitability, and that is the one that we get most nervous about with relationship to epilepsy, as opposed to the first week, which is when it just may be relationship to the actual stroke itself. Next slide. One of the things that we know is that the risk factor for an individual seizure increases in older adults. A lot of reasons for that have to do with the conditions that are very frequent in older adults. So take, for example, stroke. It increases the risk of a seizure almost 20 times compared to someone who does not have it in a same older adult. Dementia 5 to 10 times, and then you get these other conditions, depression in its own right, 6 times increased risk of seizure. Injuries, trauma, which can be as simple as a fall, increases the risk of seizure 3 times. The use of alcohol 3 times, or an infection, and we're talking like a pneumonia or urinary tract infection, 3 times as well. So the things that can occur very frequently in an older adult, defined as someone over the age of 60 or 65, can increase that risk of seizure. But older adults aren't the only group that can have an issue with strokes. Next slide. We know that in very young children, particularly infants and children, they can have strokes too. Seizures after a stroke are reported most often in children than adults. This is in kids that had some sort of problem in their birth. There's some type of stroke that occurred. The oxygen didn't work in some way, or they had some lack, some closure of a blood vessel or something in that direction. And we know this because early seizures are more common in the neonatal. These are the super young, just born children, ischemic stroke than a child, which is like a year or something along those lines older than the baby. A focal neonatal brain injury from stroke has a greater likelihood for late seizures. That's seizures that occur after that first week than strokes that occur later in childhood. So it's just a very important point to make that we're not just talking about older adults here. This is something that affects the very young as well. Next slide. We know that there is also, especially when we're talking about those late seizures, seizures that occur after the first week, that increases your risk of epilepsy. Both the ischemic and the hemorrhagic stroke accounts for about 10% of all adult epilepsy cases, and half, 50% of epilepsy cases over 60 years of age. There's a higher risk of having epilepsy after a stroke if the stroke was hemorrhagic. That means that there was blood involved. If the stroke affected one of the lobes of the brain, temporal, frontal, parietal, occipital, to name a few. And there's a higher severity of the deficit. In other words, a major big stroke increases that risk. Young patients who have stroke are also have a higher risk of developing epilepsy. And of course, if there's a family history of seizures and other genetic factors, they can also increase that risk of epilepsy. Next slide. We know that there's an increased risk of epilepsy in children after a stroke that is very common, especially at the time of the stroke. We see seizures very much working hand in hand at the same time as that stroke is occurring. Children who develop post-stroke epilepsy during the first year post-stroke sadly have more difficult or poorer developmental outcomes than those without it. And this puts a very big burden on families. There's concern about the school, education, care, and all of the worries that come with it. It's not known, however, if post-stroke epilepsy is a marker for more severe initial brain injury or if the stroke recovery is simply impaired by the seizures. Because you have to treat the seizures with medications, the question is it the EEG findings? Is it the actual medication that's creating the effect? And that's what leads a lot of questions that still need to be addressed at this time. Let's move on to another condition, and that is brain tumor-related epilepsy. Just like strokes are related to epilepsy, brain tumors are very, very commonly associated with seizures and epilepsy as well. And let's take a look at that at this time. Next slide. Seizures are common symptoms in people with primary or secondary brain tumors. That is, tumors that are either arising from the brain, that's a primary brain tumor, or secondary, that is, it metastasized to the brain. Now, seizures are often related to the abnormal cells around the tumor, the imbalance of chemicals, the inflammation that occurs. At least one seizure occurs into 80% of people who have very aggressive or malignant primary brain tumors, known as gliomas, during the course of the disease. So this is very, very common in brain tumor situations. Generally, seizures are less common in people, oddly enough, who have metastases, unless the brain area is one that is typically associated with seizures. So if you have a lesion, a tumor that goes off to metastasize, let's say in the temporal lobe, because the temporal lobe is often an area where seizures arise, we may see more seizures because it went to that part of the brain. Also, the genetic characteristics of the tumor may also affect the likelihood of seizures, and that's something that we're just beginning to know at this point. Let's take a look at the brain tumor and its relationship to epilepsy as a whole. Brain tumor-related epilepsy is very common, and more than 50% in very benign low-grade tumors, but it can also be seen in high-grade tumors, also known as glioblastomas. More benign gliomas show a high frequency of seizures than malignant gliomas, which you'd almost expect the opposite, but in a weird way, that is actually a good sign if someone has seizures related to brain tumors. A person is more likely to have a seizure or develop epilepsy if the tumor is very slow growing. And that, again, is a good thing because we may be able to do something about it permanently as opposed to a more malignant or aggressive tumor. If you look at the numbers there, a low-grade glioma, 9 out of 10 people will have epilepsy. An anaplastic glioma that's more aggressive, 7 out of 10 people. The worst of the gliomas or glioblastoma, 5 out of 10. And that gives you a sense of how that plays out. Let's go to the next slide. Now, seizures, when they occur in relationship to a brain tumor, are typically located to where the tumor is in the brain. But it can spread, and some people can have generalized tonic-clonic seizures. New seizures can be an early warning sign for the presence of a brain tumor. That's why we get MRIs in people who have a newly diagnosed seizure, just to make sure there's no evidence of a brain tumor. Now, recurrence or worsening of seizures during the course of the disease may also tell us, if things have been stable for a while, that the tumor is changing or growing and that we need to take a look. Sadly, people with brain tumors can also develop the seizure emergency known as status epilepticus, and that's something we always watch out for if someone presents with sudden onset of a seizure emergency without ever having a history of it. It makes us want to make sure we've gotten a good picture of the brain to make sure that's okay. The good news is that there are treatments. Let's take a look at those tumor treatments for epilepsy now. The same treatments that the main point of this, since we know that the tumor is causing the epilepsy, is we try to get rid of the tumor. So the things you use to treat the tumor, surgery, radiation, or chemotherapy, is going to help us in controlling those seizures. Now, about a third of brain tumor-related epilepsy is resistant to anti-seizure medications. And so that's something we have to still figure out, how do we improve our way to kind of manage that? And that we may be related to the other therapies that we can utilize to get rid of that tumor. We also know that for people who have brain tumors, if they have very difficult to manage seizures, it increases the burden of living with that tumor. Now, anti-seizure medications can be started after a single seizure, assuming that seizure is attributed to that presence of the brain tumor, that it makes sense that the seizure came from that location. And the seizure type and the patient and their individual story is what's going to determine which are the best choices for that particular person. What about surgery? Well, surgery is very important, next slide, with regards to looking at whether it can help. Surgery to remove area of brain causing seizures is very important, and we know about it. We've talked about it in a lot of these webinars in the past. About 7 in 10 people with a brain tumor who have surgery to treat the seizures find that it will stop their seizures permanently. However, the key is how much tumor can you remove, and is that area that's being removed, is that causing the seizures? And you still have to prove those points. To achieve seizure freedom or good reduction of seizures, the whole tumor or the area of the tumor that's causing the seizures has to be removed. Epilepsy surgery is possible, but not in everyone, and that's something that we always are trying to work on in terms of how to better improve quality of life. Next slide. Now, we know that seizures are common in people with brain tumors near the end of life, especially in people with late onset of epilepsy. So what we try to do in those situations is discuss the seizure medication strategy with the person affected, the family, the nursing, the hospice care. And that way a person takes the medications, taking the medications may need to be adjusted just to make sure that they can swallow it or that there's not having too many side effects. We also use rescue medications, often called benzodiazepine, to help limit or get rid of the seizures. And sometimes we don't use it at will, but we use it on a scheduled basis to make sure that everything's going to be okay. Let's take a look at another condition, and that is epilepsy and Alzheimer's disease. As Dr. Kiriakopoulos pointed out, this is a huge issue, and it continues to increase in importance given just the huge number of people that are impacted. So let's take a look at the history of seizures and epilepsy and its relationship to Alzheimer's disease specifically. Next slide. So people with Alzheimer's disease are estimated to have at least a 6-fold increase in the risk of seizures compared to the general population. Over the course of the disease, anywhere from 10 to 20% will experience some form of seizure. And the two most common type of seizures seen in Alzheimer's are focal impaired, that is, that it starts in a specific area of the brain, and that they lose awareness, and also big generalized tonic-clonic seizures. Next slide. Now, recognizing seizures in older adults can be challenging because they literally hide in plain sight. The way that seizures present in an older adult with Alzheimer's, they can present with confusion, memory deficits, dizziness. But the truth is, if you think of what I just said, Alzheimer's presents with confusion, memory problems, sometimes even reports of dizziness. And so you're not sure, is it the Alzheimer's or is it the seizures? And that's what makes this so challenging, because it isn't so obvious. Treatment decisions are complicated, and older patients are just generally more susceptible to the side effects of medication, and they also are on a lot of other meds for other conditions, which creates problems in terms of quality of life. So this is a conundrum that we are still trying to sort through in terms of how do we best help these folks. Next slide. When it comes to epilepsy and Alzheimer's disease, we know that patients with Alzheimer's are at an increased risk of developing epilepsy, and that epilepsy, for the same reason that we couldn't detect seizures, may remain undetected because we just can't diagnose what's a seizure and what is Alzheimer's, particularly in those who are cognitively impaired. Alzheimer's disease medication sadly increase the risk of seizure, and anti-seizure drugs sadly may create cognitive side effects that look like Alzheimer's. So we have to figure out what's what. Are they coexisting, the dementia and epilepsy? Is it the side effect of the medication? So oftentimes when someone is seeing a neurologist the first time with Alzheimer's, the first thing we look for is there something that's reversible? Is it the medication? Is it depression? Just to make sure that we are not running into a problem and trying to not confuse the picture. Next slide. Now, the treatment of epilepsy and Alzheimer's, similar to the other conditions, is complicated because of these cognitive side effects of anti-seizure medications, including sedation, memory problems, distraction, attention, and older seizure drugs are even worse in this regard. The drugs for Alzheimer's disease symptoms include drug groups such as acetylcholinesterase inhibitors and memantine, which again may increase the risk of seizures. Antidepressants and antipsychotics, which are often used in patients with Alzheimer's, can also increase that risk of seizures as well. So you really have to have a pretty good relationship with your physician, that they know who's who, what's what, in order to know how to best make the situation better for quality of life. Next slide. So for a long time, seizures in epilepsy and Alzheimer's were thought to be due to the neuronal damage and the inflammation that occur in the later stages of the disease. But in recent years, with a lot of research, seizures in the early stages, or even before the appearance of cognitive impairments, has been recognized. Because these seizures start in a very discrete location, they're focal, and because of similarities between people affected by Alzheimer's and people affected by temporal lobe epilepsy, a lot of attention has been drawn to the temporal lobe. We also know that the non-convulsive seizures, seizures where there's not a lot of motion, there's more staring, they're quiet, is more frequent in Alzheimer's. But the sad thing, it's also more difficult to tell that they're having a seizure, especially if the patient's confused. So temporal seizures are often unrecognized unless you do the EEG, and even in that case, EEG sometimes may be very confusing. So we're trying to understand the genetic links and find a better way to figure out what is going on. And stay tuned, because there's so much work and attention on Alzheimer's that we will know more about this relationship sooner than later. Let's look at the fourth condition, epilepsy and migraine. As you saw by the numbers earlier by Dr. Kiriakopoulos, there's almost 39 million people that have migraines. That is super common. So having epilepsy is not that unusual to have folks that have epilepsy who have migraine, and vice versa. So next slide. Headache, especially migraine, has long been associated with epilepsy. They share a lot of similar clinical features, and both of these conditions have a genetic predisposition. The genetic basis, however, isn't easy, and it's complex in both disorders. And they share the pathophysiology, which is how seizures occur. The imbalance results in recurrent episodes of altered brain function and autonomic symptoms, which is almost the automatic nervous system of the brain that helps to control things such as pulse and pressure and things of that sort. Next slide. Headache has been reported as a sole manifestation of an epileptic seizure, and it's often similarly associated the same way that seizures are. It has a preictal phase, an ictal phase, and a postictal symptoms in people with epilepsy. Migraine and epilepsy are frequently described as highly comorbid, that is, that they happen a lot together. And both conditions have individual triggers and overlaps, including stress, poor sleep, hormones, that we often see in both conditions. Next slide. There are several anti-seizure drugs that have been shown to help in treating migraine. It makes sense if migraine and epilepsy share the same mechanism by which seizures may occur or migraines may occur, then the medications for one may work for the other. We know that drugs such as valproate, gabapentin, topiramate, they have been shown to be very helpful in placebo-controlled clinical trials. And it can help to lower the use of multiple medications for treatment of people with both migraine and epilepsy. In fact, when I practice, if I know someone has both migraines and epilepsy and there's a medication that I think may be able to help both, I try to gravitate towards those medications just to make sure that we are in a way of killing two birds with one stone, so that people who I know don't like to take a lot of medications don't have to take a lot of medications if they don't need to. So with this, I hope that's given you a sense of just some of the complex relationships between epilepsy and stroke, Alzheimer's, brain tumors, and migraines.
Thank you, Dr. Sirven, for that wonderful overview, helping us to better appreciate the relationship between epilepsy and other comorbid neurologic disease. And thanks to everyone listening for your attention. What I'd like to do is go to the next slide and share with everyone ongoing ways to find resources and connect with the Epilepsy Foundation. So one way you can do this is to visit www.epilepsy.com, where you can read and learn more about epilepsy and its associated other neurologic conditions. You can call our 24/7 helpline at 1-800-332-1000 to speak to an information and resource specialist that can help to connect you to resources and supports to help you with seizures and epilepsy, both locally, at the state level, and at the federal level. And then I really want to encourage everyone to also reach out to their local Epilepsy Foundation offices, where you can be connected with support, resources, programs and services, and a community of caring individuals and families. Either the helpline or your local Epilepsy Foundation office can also help to connect you to an epilepsy center for more advanced care if you need more information about your epilepsy or the conditions related to your epilepsy and how they may be interacting. So do reach out. Finally, if I could go to the last slide, I'd like to take this opportunity to once again thank Dr. Sirven for sharing his time and expertise with all of us today. And I'd also like to thank each of you for your interest and participation. And thank you for joining our community of learners. Have a great rest of the day. Thanks, everyone.